Hello and welcome to University Hospitals Birmingham. This video is available as a resource to help you understand the pathway a patient will embark on for an awake craniotomy here at UHB. It is likely you are watching this video as you have been seen by a member of the team here, who has advised you to consider awake craniotomy surgery to remove your brain tumour. There are many different kinds of brain tumours, and until we have a diagnosis from the biopsy during the surgery, we will be unable to tell you what kind of tumour you have. Treatment for your brain tumour can be targeted once we have detailed molecular information and a diagnosis. Your case will have been referred into the Neuro-Oncology or Rehabilitation Multidisciplinary Team Meeting or MDTM at UHB for discussion and management. An MDTM happens weekly at UHB. At this meeting, your case history and imaging will be reviewed by a core team of clinicians to include a neurosurgeon, neuro-oncologist, radiologist, epileptologist, and clinical nurse specialists. Your history will be presented by a clinician and your imaging will be reviewed on screen by the core awake craniotomy team. Once this is done, a treatment plan can be formulated. You will then be contacted by a member of the team, which is likely to be your consultant secretary or clinical nurse specialist, also known as a CNS, in neuro-oncology, and invited to clinic within a few days to discuss the outcome of the MDTM. The CNS in neuro-oncology is likely to become your key worker. A key worker is a member of the team who can advise and support you through the process of investigation, diagnosis and treatment, and will be able to offer expert advice and skills so they can signpost you to the appropriate help you may need along your pathway. You will come to clinic to meet your consultant and key worker. Here you will be told what the MDTM outcome is and be given written information with details of your care plan on to keep. You will also get the opportunity to review your imaging with your consultant, along with your key worker contact details. The awake craniotomy procedure will be explained to you, and there is access to written information about this on the Trust website. At this appointment, you can ask your consultant any questions you may have, along with details of any further investigations which may happen prior to surgery. The next steps will be to have a pre-operative anaesthetic assessment to assess your physical health and fitness for the operation, an optional visit to the operating theatre to see how it will be set up on the day, or a visit to one of the wards. You may be asked to attend for a detailed scan called a functional MRI, also known as an fMRI. This is to assess the location of important areas of the brain and to determine precisely where key functions are located in the brain. Specialised mapping of the brain called a NextStim brain scanner. This is an advanced transcranial magnetic stimulation machine. To visit a speech and language therapist. This is to establish if your speech could be affected in surgery. The next step will be to come back to clinic once all investigations have been completed to review and go over the finer details of the surgery planned. At this point, you will then be contacted by the booking coordinator by letter, who will send you details of the admission process. You will then be admitted to the ward or admission lounge. Prior to theatre, you may be given a pink drink to take. This is called 5-ALA. By taking this drink, it allows the neurosurgeon to differentiate between the tumour and normal tissue during surgery. This can help the surgeon remove as much of the tumour as possible. You will be given this 3 hours before surgery begins. After administration on the ward, the patient will need to be protected from direct bright light, including the room lights with the curtains drawn. They will be brought down to theatre with all skin covered and the head covered with towels whilst in transit through high illumination areas. The patient is then brought into a very dimmed anaesthetic room with minimal lighting. Similar low light conditions will be required in theatre. A similar process and caution to light will need to be continued in recovery. Ideally, one of the corner spaces where lights can be dimmed should be identified by a nurse for the patient. Patients need to avoid exposure to light on the ward for the first 24 hours postoperatively and to strong sunlight for 1 week postoperatively, owing to the risk of photosensitivity and photodermatosis. From the ward or admission lounge, you will go to the anaesthetic room. Here you will be attached to monitors and a small thin tube cannula. A cannula will be put into your arm. The anaesthetic drugs will be administered through this and you will then go to sleep. You will have a catheter put in whilst asleep to measure urine output and a section of your hair will be removed. Local anaesthetic will be given into your scalp to numb and prepare you for the awake procedure. Once this is done, you will be moved from the anaesthetic room to the theatre and positioned correctly and comfortably with your head secured in a frame so it cannot move. The surgery then begins with an incision in the scalp in order to allow a disc of bone to be lifted and then access to the underlying brain. Our priority is to keep you comfortable during the procedure, and you will be given a calming painkiller. General anaesthetic is withdrawn and the scalp is fully numb at this point. You will gradually regain consciousness, then, when you are awake and comfortable, alert and cooperative, surgery will continue. You will be reminded your head is secured and cannot move. You will not be able to see the surgery. At this point, you can see and talk to the surgery team. You will be asked to perform simple tasks to assess your movement, speech and vision. This will help your surgeon identify important areas of the brain. These tasks may include reading, counting, moving limbs, identifying colours and shapes, and confirming personal details. During the operation, these important tasks will be continually assessed to ensure that the margin between tissue that needs to be removed and critical structures that need to be preserved remains the same. When the operation is complete, the bone is put back into place and the various layers covering the brain and scalp will be closed again. You will remain awake for this phase, but sedation can be provided if requested. Most awake craniotomy patients are comfortable during the operation, and we do our utmost to ensure you are pain-free throughout. However, some discomfort can be felt, and should this happen, please let us know so that we can adjust the sedation and provide painkillers as necessary. When you feel able, you can eat, drink and move. You will be looked after in a neurosurgical ward and monitored very closely. Towards the end of the surgery, we give painkillers and anti-sickness medicines. You may feel some discomfort and/or nausea in the period after the surgery as the drugs begin to wear off. Please do ask the nurses for more painkillers and anti-sickness medicines if you need them. Further tests of your speech, language and movement, similar to those done during the operation, may be required when you are back on the ward. You will be reviewed by the neurosurgical team after the operation to explain the details of your surgery and to answer any questions you may have. Samples of the brain tissue, or biopsies, taken during the surgery will be sent for analysis, and in time you will be advised as to any further treatment that may be necessary. During your inpatient stay, a further scan, such as a CT or MRI, will be undertaken to see how much of the affected brain tissue has been removed and to ensure no other complications have occurred. If the scan is satisfactory and you are well enough, we aim to discharge you home 24 to 48 hours after your operation. You may experience tiredness and minor head pains around your wound for the first few weeks after the operation, but this should settle down over time. We will routinely invite you to attend clinic 1 to 2 weeks after your operation to see how you are, to discuss the results of any biopsies, which are usually available by this stage, and to check your wound. Your stitches or staples will typically be removed by your GP practice nurse 7 days after your operation. You must tell your GP or clinical nurse specialist if you have any concerns after the operation, in particular if you notice any of the following symptoms: discharge from the wound, clear fluid or pus, wound swelling, temperature or fever, seizures, new symptoms of weakness in the limbs, worsening headaches or drowsiness. As with all surgery, there are possible risks, and as part of the consent process, your neurosurgeon will discuss these with you in more detail. For craniotomies, these can include infection around the wound site or rarely deep in the brain, known as meningitis, fluid leak from the wound site, bleeding, brain swelling, stroke, seizures, residual tumour, such as tumour left behind after surgery, recurrence of tumour, such as tumour regrowth after surgery, medical complications, such as a chest or urine infection or a heart attack, blood clots affecting the legs or lungs, a very small risk to life. Having the procedure awake significantly reduces the risk of causing a stroke, which causes speech or movement impairment, but does not eliminate it completely. We estimate the risk of a serious complication, such as a stroke or risk to life, to be less than 5%. One specific risk is the occurrence of seizures during the procedure whilst awake. We have methods to reduce the risk of seizures and to stop them if they were to happen. Rarely, if you become very uncomfortable during the course of the awake phase, or to help complete the operation following a seizure, we may need to restart a general anaesthetic to send you to sleep again. After the operation, when histopathology results are available, your case will again be discussed in Neuro-Oncology MDTM, an extent of surgical resection, histopathology reviewed or confirmed, and treatment plan put in place. You will then be invited back to clinic again to discuss the MDTM outcome with the neuro-oncology surgeon and CNS present. At this appointment, you will be given patient information and a personalised care plan of what happens next, with CNS contact details. We will also review your wound and medications and explain ongoing further management or referral.